Our next presenter is Rosemary Kennedy, who is the Senior Director of Nursing and Healthcare Informatics at the National Quality Forum in Washington, D.C. In addition to being an informatics domain expert, she holds many leadership roles through her work with the Health Information Management Systems Society, the American Medical Informatics Association, and the International Medical Informatics Association. She is a delegate to the International Medical Informatics Association Nursing Informatics Special Interest Group and serves as a leader of the nursing informatics communities within AMIA. She recently served as the Chief Nursing Informatics Officer for Siemens Healthcare Solutions, where she provided professional practice leadership over the development and deployment of solutions to ensure nursing practice and interdisciplinary requirements were met. Thank you, Rosemary.
Good morning. I'm Rosemary Kennedy, and it's a pleasure and an honor to be here to have this opportunity to discuss with you the intersecting role, I think, of nursing, health information technology, and performance improvement. My journey on this path really started in 1984. I was out of school a few years, and I really had a misconception. I thought that all the information that I was putting into the electronic health record as a byproduct of care delivery, I really thought that that could be used to assess quality and performance improvement. So a group of us went to the IT department and asked them for the information that we needed because we wanted to look at all the education that we were doing, particularly for cardiac patients, and we wanted to know whether we were making a difference and whether it was impacting readmission rates. And they said, well, we'll give you passwords to the electronic health system, the medical record system, the staffing and scheduling system, and the financial system, and maybe SPSS, and good luck. So we quickly realized that we would not be able to really get to the level of detail that we wanted in terms of technology, so it started this journey. Nurses are really, as my colleagues have said, the glue that holds everything together, spending much time managing healthcare data, information, and knowledge from all sources. And you heard my colleagues mention computerized provider order entry, clinical systems, financial systems. Nurses interact with data at all levels of granularity. Some are in the information technology department, using principles to integrate evidence-based guidelines into the EHR. Others are at, like where I'm at the National Quality Forum, looking at measures and identifying how they can be structured from an HIT perspective for use and reuse within the system. These roles span information technology, point-of-care delivery, process and quality improvement, as well as regulatory compliance. The decision that nurses make as they design the systems and as they put them into action, the decisions that nurses make as they create dashboards for senior management and reporting, have tremendous implications on care delivery, going from the bedside to the boardroom. In addition to the traditional role in information technology departments, informatics nurses are involved in quality and process improvement initiatives, evidenced by the HIMSS survey, which states that 60% of 492 respondents stated that nurses informatics were involved in quality initiatives. I think we're seeing the blending of nursing informatics, quality management, and performance improvement in expanding the role of informatics nurses. So they're not only designing the system, providing input, but then they're also involved in quality and process improvement and getting that information out of the system so decisions can be made. The breadth and depth of the nursing role is exemplified in the depth and the breadth of the data managed by nurses. Nurses provide a clinically rich repository that can be used for performance measurement, including nursing diagnosis, observations, findings, orders, interventions. Everything that Curtis mentioned spans a broad range of data elements that are critical in terms of patient safety and quality. The documentation is reflective of the best that we have, evidence-based guidelines, and measurement instruments are integrated. So certainly, the information entered as a byproduct of care delivery can and should be used to assess quality. So let's focus on how we get real-time quality measurement as a byproduct of automated documentation and take a real-life case example. The percentage of heart failure patients discharged home with written instructions on education material given to the patient or the caregiver at discharge, an NQF measure. In my prior role, I implemented an electronic health record using standardized terminology, so it was all structured within the data warehouse. And we thought that this would be not a big deal. We were prepared. So we sat down with our quality management colleagues to gather the information. And when you get under the covers and you look at the measure and you look at all the information that they want from the repository, we started to glaze over a little bit. And we kept saying, well, we're okay. We have structured coded information using the various standards in the models. But nonetheless, we did go into the repository and find varying levels of granularity in the information and how it's stored. Some information may be missing. Sometimes you have to go to the ICD-9 coded list when actually the patient problem list may be a more accurate source for the measurement. So there are differences between the information you need sometimes and the information you're able to get out of the system. This is fairly consistent with the research. It is conservatively estimated that centers spend 22.2 minutes per heart failure case to abstract the data, which in aggregate amounts to more than 400,000 person hours spent each year by U.S. hospitals. Mostly retrospective, time-consuming, involves human manipulation of data. The data are in different sources and different levels of granularity and varying definitions. The good news is, though, we've made significant progress, and nurses have been instrumental in advancing standardized data models and terminology and health information technology that allows for the explicit capture of the information in standardized fields that it can be readily used for measurement or improvement. However, it's not quite enough. Additional work needs to be done. And that work is on the definition and the quality measure side. A well-defined quality measure is needed. If you think about it, common data elements that are encoded logically using standard taxonomies then are structured logically into a sequence. So we have education as a code. We can use the standardized taxonomy to capture education. It can form a standardized expression, the type of education for cardiac, CHF patients. So that gives us the capability then, and we can look at how this may fit into the broader healthcare picture, delivery picture. I must give all due respect to my colleagues at NQF, Dr. Danny Rosenthal and Dr. Floyd Eisenberg, for their tremendous graphic capabilities. And now with nursing on board, we're infusing some really good nursing examples within these scenarios. And we're finding a lot of commonality, more commonality than what we thought. So we're thinking that's good. It moves us closer to a patient-centered record. But if you think about it on the left-hand side, if the measure developers are using some of the standard codes, and they're some of the same ones that we use in the electronic health record, we could then use and reuse them and integrate them into the record. So we're speaking more of a common language between both sides. Then in the center, if we actually infuse and look at interoperable HIT standards, some of them can be used, some of them need to be extended, we actually have the backbone then. And we can actually go from the clinical guideline, the actual measure, to providing care using the electronic health record and then reporting out in a performance perspective, all using the common language. So the recommendation is that many nurses are involved in these initiatives. It's critical to patient safety and quality given the depth and the breadth of the data that we collect, and that the work should continue as we move forward from a standards perspective, looking at these various standards to enable them. Also, what's critically important as well is to consider the implementation factors related to the burden of data collection and data quality. I think my colleagues referenced the fact that there are many data elements in play. Studies out there showing that nurses spend about 38% of their time documenting, and when you add the coordination of care, it's probably up closer to about 70-75% based on the Ann Henrik study. So we need to be sensitive to the burden of data collection, engage nurses in that because they are big and play a big role in the data collection, to identify methods to reduce the burden, and then also to look at the quality of the information. I think I referred to the prior example, a patient list, maybe having good quality information because it's actually used in care delivery. And I think in summary, through the creation of a comprehensive standardized information infrastructure behind quality measures and the integration of such standards within the electronic health record, there are opportunities to improve healthcare quality. Ongoing collaboration with all stakeholders will be vital. Specifically, nurses as the backbone of the healthcare system play a central role, not only in implementation, but in all facets of standards development, use of the standards at the point of care, and quality measurement. Thank you for this opportunity to provide this perspective.
Thank you, Rosemary. Our next presenter is Joyce Sensmeitzer. Joyce is the HIMSS Vice President for Informatics and is responsible for the areas of clinical informatics, standards, interoperability, privacy and security, and professional certification. Joyce received her master's degree in nursing administration from St. Xavier University, and she is board certified in nursing informatics, is certified professional in health information management systems, and it has achieved fellowship status in HIMSS. She is an adjunct faculty member at Northwestern University in Chicago and Johns Hopkins University in Baltimore. She previously served at Palos Community Hospital as a nursing coordinator implementing clinical information systems, and is an internationally recognized nurse coordinator in implementing, speaker and author of multiple book chapters, articles, and white papers. Joyce was a member of the expert panel that revised the scope and practice of nursing informatics published by the American Nursing Association in 2001. She currently serves as a technical manager for the Health Information Technology Standards Panel, a national standards harmonization project, and is the co-chair of the Alliance for Nursing Informatics, a collaboration of 25 distinct regional and national nursing informatics organizations. Thank you, Joyce.
Thank you, Linda. And I am here representing the Alliance for Nursing Informatics today and really appreciate this opportunity. ANI is a collaboration of nursing informatics groups, as Linda mentioned, and we work to really have and create a unified voice for nursing informatics. We represent 5,000 nurses, probably more than that, but we don't have a really good way to count that. The numbers increase, I think, daily. And we have 24 nursing informatics organizations that are a part of our alliance. Some of them are at the local level, regional, national, and as you heard, carrying an ANIA, also some at the international level. But each of these organizations has their own structure, and we don't govern them in any way. We just gladly work together to realize the same goals. This is a listing of some of the groups, and you heard Vicki talk about ANIA and caring. Also, HIMSS and AMIA are part of this. But ANI crosses specialty boundaries of nursing informatics as well as nursing specialties, academia, research, and even into the nursing terminology group. So it's quite a coming together of like-minded individuals. Earlier this week, I had the opportunity to present a statement to the Robert Wood Johnson Initiative focusing on the future of nursing, and that was at the Institute of Medicine. And it was really interesting to hear the different nursing perspectives as to what is important for the future. But the issue or the topic of technology just permeated the whole day. And at the end of the day, I realized that they really need us, and I'm going to say they at this time as nursing, and us as informatics nursing, because often we go to groups and we try and explain what we're about and what we do as nurses, and here they already knew that, but they know to get to the next phase and the future, and really to have healthcare reform, they need to understand and embrace technology, but it needs to be implemented in a meaningful way. And fortunately, we have the expertise among us to really help us get there. So nurses do constitute the largest number of healthcare providers, 3 million of us out there. In our frontline roles, we have a profound impact, I did do that, on the quality and effectiveness of healthcare. And we do need to be supported adequately in our knowledge-based work by electronic health record systems that are good, excellent. Nurses are also leaders in the effective use of information technology through policy initiatives, terminology and standards development, research, education, systems design, and selection. So we have quite a variety of roles.